and I would like to welcome you to this webinar on remote patient monitoring technology. I want to particularly thank Alice Borelli of Intel, a member of the Independence at Home Coalition, for volunteering to recruit speakers for this session. The purpose is educational, intended to give you some examples we hope you will find of interest, especially in relationship to Independence at Home. The AHCP, of course, does not endorse specific companies. There will be time for questions at the end, so please feel free to type them in as you listen. The speakers are listed on the agenda and include Alice Borelli, and her title is there, Jim Piles, most of you know, Michael Lemnitzer, Trent Barton, George Margelis, and Marcus Grinstadt. And they will introduce themselves as well as their companies and their products. So let us start now with Alice Borelli. Alice?
Thank you very much, Connie. And I work for Intel in the policy group, and I've had the really great honor of working with the Academy for about 5 years. And I've always wanted to use the phrase, and I'd like to thank the Academy for, it's not an Oscar, but it is a close second, for really giving us the privilege to present health IT solutions for coordinated care, along with remote patient monitoring and telehealth, as required by the Affordable Care Act. I'd also like to thank my Continua members who have supported this initiative. So, Connie, if we look at the first slide, I just wanted to give everyone a sense of what the requirements are to be an IH team. Since many of you are applying for the pilot, you probably know these, but I think you'll see in the pilot, or rather in the requirements, the specific language for remote patient monitoring requirements and mobile diagnostic technology. So as CMS developed the regulations, we were very pleased to see in the next slide, there are frequently asked questions where they delved much more deeply into what they mean. And I have the questions and answers that they provided, which I hope will be of help to you as you're completing your application for the pilot. I'm not going to read these because I think they're perfectly clear as CMS issued them, but we will take questions at the end of the program. So let us go directly to the meat of the webinar today, and let me turn the program over to your chief cheerleader and advocate, Jim Piles.
Thanks very much. Thanks, Alice. We really come a long way with Independence at Home. This has been a 10-year effort, and throughout that effort, we understood that if we were going to really save serious money in the healthcare delivery system, we were going to have to move healthcare, at least for the high-cost chronically ill, out of facilities and into the home. And the only way that was going to be possible is through the use of technology. And I want to thank, just take a moment to thank Congressman Ed Markey, Senator Ron Wyden, and Acting Administrator Tavener for all their support on this idea, because it truly is an idea whose time has come, and I think that's illustrated by the broad-based congressional and other support in the administration behind this demonstration. We're less than a week now away from the first deadline for submitting applications, so I hope everyone is going to make sure their applications are in. Connie, if we could, looks like we're jumping through the slides here. If we could go back to that first slide of mine. Oh, there you go. So very quickly, what is Independence at Home? It's home-based primary care plus technology, which in a Senate Aging Committee hearing this past year, Senator Wyden said it really is the future of healthcare. It really is the only way we can reduce healthcare costs and provide better care without cutting coverage or cutting reimbursement. So it's really a politically palatable approach for members of Congress. And it's also important to understand that while it is a Medicare demonstration project, it's also a clinical and financial delivery model that will work with high-cost beneficiaries under Medicaid, Medicare Advantage, and ultimately private insurance. We know by 2014, most private insurers are going to have to address the very highest cost beneficiaries. They're not going to be able to increase premiums or set premiums on healthcare status as they have in the past, and they're also not going to be able to limit the amounts they pay out. So private insurers are going to be much more interested in programs like this that reduce healthcare costs where they're the highest. Provides primary care in the home, coordinates care across all treatment settings. Some of you know it's based on the VA's home-based primary care model, funded entirely from savings, so there's no additional financial outlay, which is very attractive to health plans, Medicare, and others. Important for this call, it generates a long-term and sustainable source of capital to invest in technology. One of the problems we see is everyone understands that technology might be very helpful, but in this environment it's very hard to find a sustainable source of investment capital for it. Independence at Home does that. It can be used in any health plan, as I say, Medicare, Medicaid, or private insurance. Next slide, please. So why participate? And this is a question we sometimes get, and the shorthand reason is that Independence at Home is targeted, immediate, and proven. There's simply no other health reform measure out there that you can say that about. And this was an observation actually from Senator Burr's staff, a Republican from North Carolina, who was very impressed with Independence at Home because the senator's father had died last year over the course of the year, and he felt that he could really have used this benefit for his dad. Targets the 5 to 25% of beneficiaries who account for 50 to 85% of the cost. As importantly, it does not include the 50%, the bottom 50% who account for only 4% of the cost. Programs, reform programs that do that are going to have a very difficult time showing savings because you cannot reduce costs on patients who don't cost anything. It can be implemented with relatively little startup time or cost. It's not like some programs that take months or years to start up or millions of dollars of investments. It's proven to reduce costs in numerous programs across the country by 25 to 60% where those costs are highest. And most importantly, I think, or as importantly, the demo is going to produce extremely valuable data which participants in that demo can then take and use in negotiating agreements with private insurers and Medicaid plans. Next slide, please. So additional reasons, the application for participating. The application, which again is due on Monday of next week, is really quite simple. You do need to make sure that you dot all the I's and cross all the T's, make sure that every box is filled in, and we in the Academy are working with folks to make sure these applications are as strong as they can be. There's a very favorable risk-reward balance. It's one of the few programs, reform programs, that has an 80%, 20% savings share where the providers or providing entity gets 80% of savings after the first 5%. It also requires minimum savings, and CBO just came out with a study showing that programs that require savings are much more likely to achieve them. There's a continuation of all fee-for-service coverage and payments, no loss sharing, as is true with some reform measures. The quality measures that CMS came out with are really quite reasonable. There's only 14 of them, only 6 of which affect savings, and they are quite reasonable. The savings share distributions are made within 6 months of the end of the first year, which is for these types of plans, of savings sharing plans, that is really pretty quick. As I said, it's a continuing source of investment capital with the savings share for health information technology, telemonitoring, and mobile diagnostics. When we designed the legislation, we wanted to make sure that all 3 types of technology were provided for here, because you can't really compute savings without having health information technology. Telemonitoring certainly allows one to allocate the healthcare resources in a better and more efficient way. And the area where we believe is still in its relative infancy is the mobile diagnostics. And we believe as more care moves into the home and capital is available for the research and development, we think that there will be many more types of mobile diagnostic technology devices available for the home, which will allow us to do even more in the home than we've done in the past. And finally, most importantly, I think I've read every chronic care coordination study that's been done in the last 15 years, and Independence at Home is based on the findings of all of those studies. And we know it works. This program does reduce cost dramatically. It does produce better outcomes and better quality of life for the beneficiaries and their families, and it does provide patient and our beneficiary and caregiver satisfaction. With that, I'm going to turn the program over to Mr. Limnitzer from Philips so that he can talk a bit about how technology is going to be absolutely essential for the success of Independence at Home. Thank you.
Thank you, Jim. Appreciate that. What I'd like to do is kind of give you an overview, briefly, of course, to really the focus of Philips and how we've been developing an initiative to help our customers be able to manage these chronic conditions, in a favorable way, and kind of like some of the things that Jim and Alice had indicated in terms of getting results. That's really the key element of leveraging this technology to get these results. So next slide. My position is the Senior Director. I am helping to develop the home monitoring division within the United States. I've been with Philips for 5 years, and we've seen a dramatic increase in utilization of home monitoring technologies. Our customer focus is pretty broad. We have a number of health systems, those with and without affiliated home care entities. We have freestanding home care entities, both regional and national. We have disease management entities, health plans, and physician practices. So all of these health systems and entities utilize our technologies in a variety of form or fashion, and again, with a very high level of significant improvements in both outcomes and cost savings. Next slide. The portfolio that we have put together, this has been over a 5-year period. We've invested over $7 billion with a number of acquisitions. We are focused on cardiac monitoring. One of the largest growth sectors that we see is the in-home INR testing. This allows patients to test their coagulation levels in their home. They don't have to go to the lab and have their blood drawn. This is a call center application that we can track patients' activity. We can work with physicians and cardiologists if patients are out of range. This is a Part B billable type service. On the top side of the screen is the telehealth portion. I'll go into a little more detail of that on the next slide. But Lifeline is our personal emergency response. Being able to track patients where they can live independently at home safely. We recently released a new device that is actually it's an auto alert. It actually will track and identify if a patient has fallen, and within 30 seconds, if the individual does not respond, we integrate some kind of or implement some kind of a follow-up position, either calling a neighbor or calling 911. Servicing well over 700,000 patients for individuals on a daily basis. We have a medication dispensing service which allows you to pre-program the dispensing of medications. You can do up to 6 doses per day, up to 45 days. And again, just helps those individuals where not just reminders do the trick, but actually dispense the medication. And if they don't respond that they've taken their medication, within 90 minutes it automatically contacts the caregiver or the physician, notifying them that the patient has missed their medication. And then to round that up, the sleep apnea and respiratory products with Respironics was a large acquisition. Again, your CPAP, BiPAP systems that you can track remotely. You can see if they're receiving the right dosage. You can see if the masks are leaking, all on a web application. Next slide. So the telemonitoring solution that we are focused on, and really what we find is generating the most significant reductions in readmission, is the ability to provide vital signs, educational information, surveys. You can do satisfaction surveys. You can do very specific surveys based on any signs and symptoms, reminders. All of this is available in the home with any type of communication, either through a landline or through a cellular connection. We have medical devices that are wireless that will work anywhere in the home, so they can place the scale in the bathroom and just step on the scale, and the reading from all medical devices automatically transmit to a hub, and the hub is located right below the scale there. And that information is automatically transmitted to the Philips web portal, and then you can log in, and there's alerts features, there's functions. You can identify patients that have triggered an out-of-range alert and be able to then identify what is out of range and then be able to interact with the patient. We also have validated risk assessment tools that help you identify individuals that are at high risk for readmission. The information can be customized, so if you want to use the national standards that we use, either American Heart, American Diabetes, for example, you can also edit our content, or you can create your own content to be helping you to really drive down to the specific needs of an individual. We primarily use a rental model, so it minimizes the capital outflow at the beginning of any project. It also allows you to upgrade to new technology as we release that over the next several years. And we also have developed HL7 data interfaces, so that allows us to push data into medical records. So you can use both our web portal, but also you can use your own EMRs. We have select applications right now, so and we're developing those over the next several years. So again, helps make the program seamless that you can monitor data. Next slide, please. And in summary, just to give you some case examples, these are over the last 4 years. We've had at least one customer make some public statements in terms of their programs, but Banner Health System in Arizona, just 550 patients over 3 years. They had a readmission rate of 3.8% for heart failure patients during a 30-day post-discharge. Centera Health System in Virginia is another multi-hospital system, primarily focused on heart failure, but they continually document a 70% reduction in readmissions, primarily heart failure, but they also replicated that with diabetes patients. They also have developed a lot of hospital home initiatives and other elements that can be, and some of those articles are published. Residential, which is a freestanding home care agency, just last year announced a 3% readmission rate, covering 3,000 patients that they had monitored. And then just this year, in the United Kingdom, which is the largest pilot to date for telehealth or telemonitoring program, some very preliminary but significant reductions here. This is a white paper. This is a peer-reviewed paper. It isn't currently being reviewed right now. It should be published probably mid-year, but again, has very promising results. So again, Philips has made a significant investment in helping manage these chronic conditions in the home, and we appreciate being able to participate on this call. Thank you.
Thank you, Michael. Now Trent Barton, co-founder, CEO of My Doctor Connection.
Good afternoon. Thank you for having us. We wanted to let you know that we are, if you could click the slide.
Yeah,
real
I've
quick.
got, yeah.
We are, our entire mantra is we bring the doctor home. We're the only company out in the current marketplace right now that is a bundled software technology combining recordable telemedicine and chronic disease management services. They integrate into the EMR, and what that really means is we allow a patient to stop being reactive in their health environment to being proactive. We allow them to take control for the first time.
with the doctor and the plan, the care team, to make sure that their plan of care is done correctly. That is a significant movement in the market. We are the only ones that actually can do a full face-to-face video telemedicine visit and record it and automatically have that dropped right into the electronic medical record, which is a meaningful use certified EMR platform. That's what doctors are wanting, and that's certainly what patients have been demanding. Next slide. We're also the only one that offer a patent pending integration cutting edge. So when the doctor wants to have a solution, one-stop shop, they come to us and they can get that. We are partnered with Care Innovations. Marcus is going to be speaking in a few minutes, and they've been a great partner. We've also partnered with McKesson and Relay Health. That is a key strategic alliance that we've formed because we know that as the doctors are needing, they're going to need the support and the infrastructure and the trust that their needs are going to be taken care of. We link patients and physicians, hospitals, pharmacies, local health department clinics, and health care agencies with the insurance carriers engaging in their own care, because when it's a collaborative environment, it works for all. Next slide.
I have it up.
There we go. Let me walk you through what that workflow looks like. Basically, you've got the patient down at the lower left. The patient on a daily basis can be asked any question from, are you wearing your compression socks, to have you taken your medication, to a whole host of things. And I can ask them, customize it where they can ask a certain question on every Tuesday. So we can take care of that dementia patient. We can take care of that congestive heart failure. All those varying degrees of chronic diseases we can handle. Those results are automatically uploaded into a nurse care manager that's one of ours. We're the ones that monitor that and make sure that it's being done correctly. But we can also hand that off to the doctor's staff. So if the doctor wants to handle that themselves, we can work within their integration, their workflow. That information, of course, is collected and gotten through a wireless internet. So when the nurse care manager sees a result, they can immediately interface with the patient face-to-face video. That is a key component and a huge improvement in the marketplace right now. And then all those results are automatically dropped into the EMR. Why? The doctor should only have to go to one place to get the information. By the end of 2012, we will have a lot more offerings to integrate into the EMR. The EMR will be customizable, but will also be looking towards forming relationships with additional carriers. Next slide. Let me walk you through, if you could just click 4 times so that all 4 of these come up real quick. Basically, those are the 4 steps that the care manager and the patient, and the reason we want to centralize and make sure that it is known is that the patient and the doctor and the care manager are all in one model. And they also can be, the patient can be anywhere in the United States as long as they have internet, broadband, or even a hotspot on their phone. We can get this information to them. We keep them in the home as long as possible instead of taking them to the hospital, taking them to the ER, or putting them in a paid facility. Next slide. All the information comes in on a daily basis. It's either red, yellow, or green alert. Those threshold violations are immediately attended to either by the doctor's staff or it can be attended by us. And we will take the measured response according to what it is. If it's a diabetic and their blood sugar shows a spike and then they're we can't get a hold of them, we're going to immediately deploy emergency response. But if it's someone that has a breathing and they're their medication that they're taking, the allergies are getting them, then we can certainly have a nurse interface with the patient. Next slide. And this is all the information that's available to the doctor. It has all the measurements, assessments, reminders, patients, and reports. So you can trend line, you can predict. Instead of being reactive, you can be proactive. And it's all integrated into the EMR one-stop shop for the information. We are the only company in the nation that currently has this all integrated into one. Next slide. Oh, okay. I guess that's our last slide.
That's what we're got.
I thought there was one more slide. Sorry about that.
All right. Well, thank you so much, Trent.
Mm-hmm.
Our next speaker is George Margelis from Australia.
So good morning, everybody, and greetings from Sydney, Australia. My name is Dr. George Margelis. I'm the General Manager for Care Innovations here in Australia. I'm a physician by training. Bulk part of my clinical experience has been in geriatric medicine. And I was involved very much here in Australia in our shift from acute care, hospitals care for most geriatric patients to a very strong community care model. I guess what gives me a perspective here is that in Australia we've actually had a very strong primary care focus now for many years, and we also have universal insurance coverage. So I guess that gives me a perspective on where the US is going. To me, the Independence at Home Act is really quite an exciting shift in the way healthcare is delivered in the US, and it's mirrored by exactly what's happening here in Australia and what's happening in Europe and most of the developed economies. How we respond to those changes is very important. Shifting care from the acute care sector back into the home meets all those Institute of Health improvement requirements around better access, better quality, and decreased cost. And the inclusion of technology is critical to deliver on these goals. However, the greatest challenge we face is that to date, the evidence around this has been fairly ambiguous. And it is my belief that the reason for this is that the technology has not been integrated into the clinical model. It's usually just been attached as a superfluous add-on. I use a couple of examples. The Chaudhry study that was published in the New England Journal of Medicine in late 2010, which used an automated telephone response system, didn't show great results. And as we look also at the Medicare Health Support Disease Management Pilot, which was reported last month in the same journal, they used nurse call centers and they had similarly disappointing results. The key issue is that the solutions used did not allow for the integration into the physician's clinical model, but rather all they did was add an extra overhead to delivery of care. So at Care Innovations, we've been working on a solution that can not only be integrated with the information systems of the physicians, but also has the flexibility to integrate with their workflow. What does that mean? It allows the physician to determine what level of interaction they require with the patient based on their clinical need. This can be as little as having them take a measurement or answer a question, and can be escalated all the way up to a one-on-one video conference or the delivery of specific educational material at a time which is most beneficial for that patient. So that flexibility to deliver what is needed at the time it is needed as compared to just running standard algorithmic processes is critical. It allows for collaboration and cooperation between the care providers because they are all seeing the same information and they're sharing on that information, and that builds trust between the care team and the patient. It helps the patient become better educated about the condition without removing the bond between them and their care team. And again, that self-management tool aspect of it is critical because as we manage more and more of these patients in their homes, they have to become a participant in the process. It's no longer just a passive process. So part of our goal is to provide a virtual care coordination solution that enhances that entire clinical relationship while taking out a lot of the redundant costs. And I think that's the key for Independence at Home, is providing a scalable, flexible solution and taking out the wastage which is so common in our healthcare system. I'll pass on to my colleague Marcus Grinstock, who'll show you more about the technology solution. I'm happy to answer any questions about our experiences here in Australia using these sort of solutions going forward. Thank you.
Thank you. Marcus?
Thanks, George. Always happy to come down and check those out in person if you need me down there. Anyhow, I'll go into a little more detail about the guide and how we got to the point we're at. But before I jump into that, I'm really excited to see the Independence at Home pilot program, as George talked about, driving the physicians and nurse practitioners leading that care team and integrating with both a data repository, as Trent showed, an EMR, and the home monitoring solutions. We've been in this space for about 10 years now, I'll talk through that a little bit, but the physician practice and primary care has been an area that we've felt for some time is critical in terms of engagement in the process. And in fact, a pilot program like this where the physician practice is actually in the lead is a fantastic direction. So if you can go ahead and, my name there on the slide, Marcus Grindstaff. I'm the Director of Product Management for Care Innovations. We're an Intel GE company combining the forces of Intel and GE to tackle some of the challenges we're talking about today. Go ahead and go to the next slide.